So, acute hypoxemic respiratory failure and oxygen therapy. This is a two-part lecture. You are going to get one part. Trust me, you don't want another 2 hours of lecture, so we're going to keep it brief, short. I'm going to give you what you need to know about intrinsic hypoxemic respiratory failure, so really intrinsic to the lungs. There's different forms of hypoxemic, or I should say hypoxemia and hypoxia, but we're going to really just focus entirely on the lungs here. And of course, you know, there's a lot of overlap when it comes to the different forms of hypoxemic respiratory failure. I break it up into different classifications and different pathophysiology for you to understand. But really, I'll show you this at the end, that there's quite a bit of overlap in the disease physiologies that we see. To make this more interesting, I have broken it up into case-based, again, utilizing ultrasound, really to show you how important it is for you to develop these skills and how they can be beneficial in the management of your patients and in the workup of your patients. So some quick objectives for you guys: to know what the different 4 types of respiratory failure are, describe the basic pathophysiology. You will be able to do this like champs when I'm done with you. To utilize ultrasound in your approach to the patient with hypoxemia. After last lecture, you can't do ultrasound, then there's nothing else we can really do, because we went through so much of the physiology that you'll see, the A lines, the B lines, the C profile. So you have all the weapons in your arsenal to really come up with a broad differential for your patients. And then, if we were to continue this, to be able to describe the various oxygen therapies. So basic terminology and definitions. This is a busy slide. Sit back, relax. Let me just tell you about the slide. You don't need to crunch the text here and try and figure everything out. I just want to introduce you to some basic terminologies, because many people get these wrong, and I don't want you to get these wrong. I want you to understand when we say certain things, and if people say things that are incorrect, know exactly what's going on and what the correct terminology is. So SaO2 is arterial oxygen saturation. That's a direct measure of the percentage of hemoglobin saturated with oxygen. That's not typically what we use. We use an SpO2, so a peripheral oxygen saturation, which is a surrogate. It's calculated using pulse oximetry, so wavelengths of light. And it's the percentage of hemoglobin saturated with oxygen, but it's done non-invasively with pulse oximetry. PaO2, amount of oxygen dissolved in plasma. You should be familiar with that terminology, because we need this to get an AA gradient, right? So we've talked about AA gradients in the past. The difference between the amount of oxygen in the alveoli, which is the capital A, and the amount in plasma, so your PaO2 of the blood. The important concept when it comes to AA gradients is that there's no set normal value, right? Don't say, if the number says 4 to 8 on the ABG or whatever you're looking, that's not the correct value. It differs by age, as VQ changes with age, as pulmonary physiology changes with age, or if somebody has underlying disease comorbidities, their AA gradient may be more, maybe larger. So in order to figure out where their AA gradient is within a normal range, you can take a few formulas. One is 2.5 plus 0.21 times the age, or a simple way is age divided by 4 plus 4. That's typically what we teach, something easy that we can utilize on the boards for the workup of hypoxemic respiratory failure. It's important to know AA gradients, because the different types of respiratory failure have different AA gradients. Some have normal, some have large AA gradients. And this can help you decipher which direction you go in. The PF ratio, if you've rounded in the ICU for any considerable amount of time, you've heard this again, especially when it comes to ARDS. You guys have had a lot of COVID exposure. I think you guys are in a great position to know a lot about vent physiology, to know a lot about pulmonary physiology, because you just had to deal with so many COVID patients, which is the unfortunate reality over the last 2-3 years. But PF ratio is important, part of the Berlin criteria in the diagnosis of ARDS. It's the arterial O2 divided by the FiO2, and less than 300 is abnormal. And then we break it up into mild, moderate, and severe. Mild 200 to 300, moderate 100 to 200, and severe anything less than 100. Important because it also has implications for mortality when it comes to ARDS. Hypoxemia and hypoxia are not the same. People use these interchangeably. They say it like they're the same word. They're not. Hypoxemia is a low arterial blood oxygen. Hypoxia is insufficient oxygen supply to tissue, right? So hypoxemia can lead to hypoxia, but it's not the only cause. Somebody has cardiogenic shock. They could have hypoxia, but they might not be hypoxemic. Somebody has cyanide toxicity. They have tissue hypoxia because they can't utilize oxygen, but they might not be hypoxemic. Somebody has something like sepsis, severe sepsis, and an elevated lactate. That's a sign of tissue hypoxia because they're not able to utilize oxygen at the cellular level, but they are not hypoxemic. They might be on room air, but they have a lactate of 5, right? So hypoxemia, hypoxia, different. I don't like this slide. It's a lot of words, a lot of stuff, but it's necessary if we're going to talk about, the basics of pulmonary physiology. So let's get to some more interesting stuff. So how do we classify respiratory failure? We have 4 types. Type 1, the one we're going to be talking about today, is hypoxemic respiratory failure. There's 5 main mechanisms. Type 2 is hypercapnic or hypercarbic. Somebody once asked me what's the difference between the two. There is no difference. They're both the same. Hypercapnic is hypercarbia. Type 3 is a perioperative respiratory failure. Type 4 is respiratory failure due to shock, right? So you have that patient who is in septic shock, who's on 3 pressors. You put them on a ventilator because you know that the pulmonary system can require 30 to 40% of the cardiac output. And so you're doing that to allow them to rest. So people who are in a shock state, whether it's septic shock or cardiogenic shock, that's a type 4 respiratory failure. And again, there can be overlaps between the different types, right? You can have somebody with hypoxemic and hypercapnic respiratory failure. So this is just how we classify, and the physiology is just broken up so you can understand it and really conceptualize it to better understand what's going on with your patients. So here's a lung. It's a nice crude cartoon, but it gets the point done. We have lungs. Usually we have 2 of them. There's vasculature, which is going to the lungs. We have different zones. We call these West zones, just by the way we describe it, West zone 1, 2, and 3. Now, normal VQ is anywhere between 0.8 and 0.9. V is ventilation, Q is perfusion. And there's a ratio between the two, right? I have ventilated lungs and there's some blood flow that goes to different regions of the lungs. VQ is about 0.8 to 0.9, allowing for some abnormalities, some basic abnormalities in the lungs, right? Nothing is 100% perfect. But there's differences in VQ in different areas of the lung. So VQ is greatest at the apex, but when the patient is sitting up due to gravity, ventilation increases as we go down to the base. As you can see here, you have larger lungs at the bases, and the alveoli right here has more recruitability. So ventilation, when the patient is upright, is greatest at the bases. Perfusion also increases and is greatest at the bases, as you can see here, but perfusion is much greater than ventilation at the bases. So the VQ is lower. Does that make sense? So just so you understand, this is a normal lung. And if we then take a look at this alveoli right here and the corresponding capillary, this is how it occurs. I have venous blood coming in, oxygen coming into the alveolus. I engage in gas exchange, oxygen and carbon dioxide get exchanged, and then I go to the arterial system. And we're going to be using this kind of picture to understand the physiology of what's going on in the lungs, with some ultrasound images to keep it fun. So you guys are on night float, you're coming in. I don't know, you come in, what do you come in at 8:30, 9 o'clock now? You come in and you put your stuff down and you get your first admission. So you have an 84-year-old guy, hypertension, hyperlipidemia, CAD. Sorry, let me go back. Altered mental status, initial vital signs stable, CT head negative for bleed or infarct. Admitted, I just recognized the typo that I see there. Admitted to the medicine service for workup of encephalopathy. On evaluation, you notice the patient to be tachypnic, hypoxemic, and tachycardic to 120s. You whip out the ultrasound and you obtain these views. What are the ultrasound findings obtained in the interior views? So what do we have here? So I gave you guys the fresh, the warm up with all the POCUS. So this is no problem now.
He has a B profile on the right lung and A profile on the left.
Good. And now we take a look in the right side, the right axillary region. What do we have here?
Looks like hepatization of the lung
Good.
with some air bronchograms.
Some air bronchograms, right? And definitely, what do we call these, Nero? Are these static or are they dynamic?
Dynamic.
Dynamic, right? We can really see these moving. And with dynamic air bronchograms, they move when the patient's breathing. It's not me moving the probe and creating, movement in, in the bronchograms, which you can do. And there's actually some literature out there. If you break the lung up into different zones and you quantify the amount of static air bronchograms, you can more reliably predict if the patient has pneumonia. Because like I said, when you see something like this, it points you in the direction of pneumonia, but it is not diagnostic. You can still have atelectasis with dynamic air bronchograms, just like you can still have pneumonia with static air bronchograms. But this points us in a different direction. So you had this patient come in. What's the most likely etiology to this patient's hypoxemia?
Pneumonia.
Good. So now you get the chest x-ray and we can read this. Nero, what do you think of the chest x-ray?
I see a consolidation in the right lower lobe.
And I have it in yellow, just in case anyone.
Right middle and lower lobe.
So right lower, it's also involving the right middle because there is some involvement along that right heart border. If you think of the right middle lobe, it's like a band going along this right heart border and goes a little up like this because it goes posteriorly. So anything in this area is the right middle lobe, but definitely right lower and right middle lobe. Great. So the first mechanism of hypoxemia, something that we are all familiar with, whether you realize it or not, it's those patients with pneumonia and a shunt, right? So that right to left shunt, we call it wasted perfusion or low VQ. So basically blood passes from the right side to the left side of the heart without being oxygenated because it's bypassing the lungs. So if you think about it, you have a pneumonia in the alveoli, so you're having perfusion of non-ventilated alveoli. So that venous gas is then going to get mixed with other gas, which is getting oxygenated to dilute it. And this is where you have a shunt. There's different types of shunts. There's a physiological shunt, and then there's an anatomic shunt. The physiological shunts is the things that we're more familiar with, the pneumonias, the ARDSs, the pulmonary edemas. But the anatomic shunts are something we need to keep in mind, and we never want to forget them because they're important for our workup and to identify where somebody may be profoundly hypoxemic. So the anatomic are intracardiac shunts and intrapulmonary shunts. The intracardiac being a PFO, an ASD, or a VSD, where you're going from the right to the left side of the heart and bypassing the lungs entirely. And you want to calculate shunt fractions when you're dealing with patients who have these intracardiac shunts. The intrapulmonary shunts can be either congenital, so you can have pulmonary AVMs, or they could be acquired, such as a hepatopulmonary syndrome, where you have increased nitric oxide, right? And then you have dilation and creation of these capillaries in the basal part of the lungs. And so these patients become hypoxemic with due to an intrapulmonary shunt, and they have something called platypnea, orthodeoxia syndrome. Think of it as the opposite of people with heart failure. So they feel better laying flat, but when they sit up, they become hypoxemic and tachypnic because, like I showed you, the blood flow then goes down to the bases of the lung, and that's where those pulmonary AVMs are in people with hepatopulmonary syndrome, and then they become hypoxemic. When they become hypoxemic, they then become tachypnic. So when you have hepatopulmonary syndrome, a common feature, or I should say not a common, but a feature you may witness is something called platypnea orthodeoxia. When you're dealing with these anatomic shunts, to differentiate between an intracardiac and an intrapulmonary, we do something called a bubble study, right? So I did this, maybe it was this week with Elizabeth. There was somebody who came in very profoundly hypoxemic. We did a bubble study in the ED. It's so easy to perform. Get a good apical 4 or get a good subcostal view. Get 2 syringes, one with saline and a 3-way stopcock. You just go back and forth agitating up the saline when you have a good view of the heart, and then you just push the agitated saline in, and what you will see is bubbles going onto the right atrium into the right ventricle. If there's an intracardiac shunt within 3 cardiac cycles, you'll see it going into the left side of the heart. If there's an intrapulmonary shunt within 5 to 6 cardiac cycles, you'll see it going into the left side of the heart. If there's no shunt at all, the pulmonary vasculature will absorb those micro bubbles and you won't see anything going into the left side of the heart. So an agitated saline study or bubble study is something that we can routinely perform to look for these anatomic shunts. Big features when you're dealing with shunt physiology is they're profoundly hypoxemic. So they have an increase in AA gradient and they're difficult to correct with supplemental O2. This is the classic patient who's on a ventilator, 100%, PEEP of 18 or 20, and they're saturating 91%, right? You're giving them all this oxygen and you're having trouble ventilating them. So profound hypoxemia is a very characteristic feature of shunt physiology. We break it down. We look at the alveolus. This is what we talked about. I have something, pneumonia involving my alveoli. Venous blood is coming in, not engaging in any gas exchange, then going back to the arterial side. And depending on how much shunt I have, it can be quite substantial. You can see how it can then also dilute this healthy blood, which is being oxygenated. This is all mixing in here. And so now I'm diluting all the blood, and that's why I'm so profoundly hypoxemic. Good. Any questions on shunt physiology? Was I able to break it down for you guys? Now you understand it completely? Good. So let's take it to admission number 2. So you got a little break. You went down to the cafeteria area where you guys have all of that phenomenal food stacked up, all the sandwiches that I never got to have when I was a resident. So you got your food and now you're seeing the second admission. An 84-year-old female, medical history of dementia. She's bedbound, hypertension, CAD, GERD, coming from a nursing home to the ED for increased work of breathing. An ED, borderline hypotensive, but tachycardic to 127, tachypnic, hypoxemic to 86% on Romer. And like most people from a nursing home, she was started on vancomycin and cefepime and admitted to the medicine service. It sounds like the standard treatment. So we get the chest x-ray. And what do you guys think of this chest x-ray?
Hyperinflated lungs, maybe, but it's clean. She doesn't have any consolidations. She doesn't have any pleural effusions. The heart is not big.
Good. I agree with you. I don't see any focal opacity. I don't see any significant abnormality. And you know, if you're a sepsis person, you might say, well, let's give a few liters of fluid and watch it blossom. Right? Everyone loves that. Let's watch it blossom the next day. But I don't see anything here on the chest x-ray, which is good for the patient. So now you take out the ultrasound because you're trying to figure out, hey, what's going on with this patient? So what do we see here?
A profile, both sides.
Excellent. A profile, both sides, bilateral A profile. Great.
And now we have the D sign and Marconnell sign.
Excellent. See, you guys are loving your signs. I'm giving you all the signs here. So personal short access, LV, RV, just to familiarize ourselves again, papillary muscles. You can definitely see flattening and paradoxical septal wall motion. It's tough to say if this is only occurring during systole or diastole. You really, again, have to get, EKG leads on here and get a QRS, but it looks like systole, systole, systole. So maybe more in diastole, you're having this septal wall motion. We go over to the apical 4-chamber view, which is more of an RV focused apical 4-chamber view. So, you can maneuver the apical 4 to get an RV focused view. It's a standard view to get. Those who are interested, I can show you. Here's the LA, here's the LV, RA, RV. You get a little piece of the aortic outflow tract right here. And then what do we see? So you had said McConnell sign, right? So dilated and hypokinetic right ventricle, hyperkinesis of the excuse me, of the RV apex, because you have this hyperdynamic left ventricle, so pulling that thin-walled RV apex as it's contracting so heavily because you're in a shock state. Is this a good sign or a bad sign? For patients? It's bad.
Yeah.
Right, it's bad. Good. So based on the lung and cardiac ultrasound findings, what is the most likely etiology to this patient's hypoxemia?
Pulmonary embolism.
Good. So now you have a whole bunch of pulmonary embolism in the lung, right? So this is what you might find when you have a patient like this. So why do they become hypoxemic? Well, this is where we're typically getting into something called dead space ventilation or high VQ mismatch. So I'm ventilating an area, I'm ventilating the alveoli, but I have blood clot through the different areas of the lung, and I'm not able to perfuse those lung regions, right? So pulmonary gas exchange is impaired. But if many of you have seen our PE patients, a lot of the time, they have significant clot burden, and many of them are on like 2-4 liters of nasal cannula, right? They're not requiring intubation. They're not on BiPAP or high flow all the time. Certainly some may be, but you'll see a lot of these patients who are doing okay on nasal cannula. So hypoxemia is usually corrected with supplemental oxygen. That's one of the features of dead space ventilation. Again, when you're dealing with hypercapnia, that's not something you always see because a lot of the time these patients are tachypnic and they're hyperventilating, so they're blowing off the carbon dioxide. And the etiologies, like I said, in addition to pulmonary embolism, pneumonia can also cause this as well. There's overlap. ARDS can cause this. Just like when you have ARDS and you have a pneumonia, microthrombi is a predominant feature of ARDS, so little clots within the lungs. So that can lead to dead space ventilation. It's also very common in ARDS to have dysfunctional hypoxemic pulmonary vasoconstriction. So my lungs are, great when it comes to oxygen physiology. So when I have area of the lungs which are getting a lot of oxygen, the pulmonary vessels dilate. When I have areas of the lung which are not getting oxygen, they tend to constrict. So that's normal. When I have ARDS or other forms of inflammation in the lungs, that's dysfunctional. So in some cases, I could have good ventilated, oxygenated areas, and the pulmonary vessels are constricting there. And I have poorly ventilated areas of the lungs, and you have vasodilation of those vessels. So dysfunctional hypoxic vasoconstriction is something we can see. You can also have emphysema and other lung diseases, which can lead to destruction of the capillary of the endothelium, and that can lead to dead space ventilation. So this is the second mechanism of hypoxemia. So obviously, these PEs are an extreme form of it, but it can occur from numerous etiologies. We then look at our healthy lung, and we look at the alveolus again. This is our healthy alveoli. We had talked about shunt. Here with dead space, I'm breathing in and out. My alveolar O2 is fine, right? There's nothing wrong with that, but I'm not perfusing this lung. I'm not engaging in any gas exchange here. And the more of these alveolar units that are affected, the worse the gas exchange gets, right? And then the worse the hypoxemia gets. Good. All right, any questions on the second mechanism? No? Straightforward, right? Easy to understand. Good. So third admission, 65-year-old man, medical history of CAD, hypertension, former smoker with frequent hospitalizations due to shortness of breath, coming to the ED again with shortness of breath, this non-productive dry cough, this exertional dyspnea. He's normotensive, tachypnic, hypoxemic, afebrile. Labs are fine, no leukocytosis. BNP is unremarkable. BNP is 42. Sabrat had to get the BNP, rule out heart failure. Troponin's negative. The ED places him on non-rebreather with improvement to 92%. They start vancomycin and cefepime for suspected pneumonia, and they admit to the medicine service. They like to just throw on non-rebreather and say, hey, he looks okay. So we'll admit to the medicine service. So you guys are going down there, and you take the ultrasound with you, and you get these views.
B profile bilaterally.
Good, bilateral B profile, right? Excellent. So now we get some echo views.
I think grossly normal ventricular functions.
Good. I agree. Peristernal short, LV, RV. Looks like we have good contractility here at the level of the papillary muscles. Apical four chamber. Again, to familiarize ourselves, LA, LV, mitral valve, RA, RV, tricuspid valve. And then again, it looks like we have good contractility of the left ventricle. And then looking here, looks like we have good TAPSE, right, of the right ventricle. So good ventricular function. So you obtained a chest x-ray as part of the diagnostic workup. So what do we think of this chest x-ray?
Awful.
Awful. I like it. I wish all radiology residents would read it like the awful chest x-ray.
There's like a bad sign kind of a thingy. I don't know. Looks like bad sign.
Okay. So definitely, I mean, it's located in you know, these areas down here. So do you guys think it looks like dense consolidation? Like if you were to take this heart and put it on the area of the lung, is it a dense consolidation? No, I see Nero shaking her head. Okay.
More of like a reticular nodular pattern. Oh.
Nero, you should be going into pulm critical care and not cardiology, because that is a reticular pattern, right? You can see these lace-like appearance, right? Can you appreciate that, this lacy-like appearance? And yes, you have some areas which I like to say have more confluent opacity, but in general, this is a lace-like appearance, so a reticular opacities. Good. And I agree with you, Nor. It's awful. If I see this, this is bad. This is awful. And if you see this, what else would you want to get? So you have this patient and they're okay. They're on non-rebreather. They're hypoxemic. They're getting their antibiotics. You see this chest x-ray now. You see this ultrasound finding. So you guys are on. What are you going to tell the interns? Like, well, what the hell do we do? What are you going to tell them? What do you want to get?
BBG, high resolution CT maybe.
Oh, good. So
ILD.
you get your CT and you see this. So what do we see here?
Honeycomb.
The honeycomb. I like it. So what do we think when we see this honeycombing?
Bronchiectasis and
Good. I see bronchiectasis too. That's excellent.
ILD.
ILD.
Good. So this would actually be a very characteristic, what we call a UIP pattern, usual interstitial pneumonia. So a usual interstitial pneumonia can be seen in many forms of ILD in people who, you know, in this particular patient, a 65-year-old male, former smoker, you're leaning towards a pulmonary fibrosis or maybe an IPF. Idiopathic pulmonary fibrosis has to be ruled out by looking for obviously rheumatological conditions, so requires extensive testing. But this is a typical UIP pattern, usual interstitial pneumonia. By that I mean you have honeycombing, so bibasilar predominant, so basilar predominant honeycombing, where you have these stacked bronchiectasis, right? You have traction bronchiectasis, so these are the bronchi, so you see dilated airways and this traction bronchiectasis. And then you have minimal ground glass, so I don't see a lot of ground glass in here, right? So that's a high probability for UIP. Now we call this out here bronchiolectasis because this is involving the bronchioles, right? This distal airway. So bronchiolectasis, when it's out here, when we're involving the bronchi like this is bronchiectasis. So definitely larger than the corresponding vessel, right? So this is like varicose bronchiectasis. So what do you think is the most likely etiology to the patient's hypoxemia? We already said it's not a surprise.
ILD.
Yeah, like a pulmonary fibrosis, right? ILD, pulmonary fibrosis. This is actually the gross pathology of a lung with pulmonary fibrosis, and you can actually see the honeycombing and all the bronchiectasis in the airways. And just looking at this lung, I don't need to go into in-depth pathophysiology as to why somebody like this is hypoxemic. Nevertheless, I will. And one of the main mechanisms, at least early on in pulmonary fibrosis, is a limitation of diffusion. So we're very familiar with the alveolar epithelium. We have the alveolar endothelium right next to it. That is a very thin border. There's only 2 cells. There's really no matrix in between the two at the alveolar level. It's alveolar epithelium. It's capillary endothelium. That's it. And this is why you have effective gas exchange between the lungs and the capillary blood vessels. So as you can imagine, if I take this lung and I zoom in on an area and I look at the level of the alveoli, if I have this thickening of the alveolar epithelium, you can see how it's going to impair the gas exchange to the corresponding endothelium. And this is how it starts with pulmonary fibrosis and other forms of diseases that lead to diffusion limitation. When you're dealing with emphysema, it's the same thing. You have destruction of the epithelium, and then you can also have destruction of the corresponding endothelium, right? And then you impair that gas exchange. So you lead to this diffusion limitation. Characteristic and classic feature of diffusion limitation is these patients, their hypoxemia gets much worse with exertion. And this is one of the reasons why we do a 6-minute walk test with some of these patients, right? To see how they're improving with treatment or getting worse. So this is the mechanism of hypoxemia with pulmonary fibrosis. Can be done with emphysema. You can also see this with ARDS. Just imagine if this lung has pneumonia and then you have exudate and hyaline membrane formation because you have denudation of the alveolar epithelium. This becomes thicker. You're not going to engage in gas exchange. Right, so another mechanism. So the third mechanism that we need to be familiar with is diffusion limitation. Now there's 2 more that you're not going to see that often. This one, if somebody's climbing up a mountain or going into high altitude, they can have low atmospheric oxygen. So it makes sense. So you're here, you're climbing up the mountain, you're starting here, you're working your way up. As you work your way up, the barometric pressure, which is according to the alveolar gas equation, 760, as you go up higher, it starts to drop, 600, 500, 400. As this becomes lower, you can go over here to the alveolar gas equation. This comes from 760 down to 400 or 300. You can see how your alveolar oxygen is going to be much lower. So your diffusion gradient between the alveoli into the artery is much lower. Normally, in all of us, because we're not accustomed to that, we're going to be symptomatic. You're going to be hypoxemic. You can then have high altitude sickness and other forms of that. Those who have adjusted, as I mentioned to you, hypoxemia isn't the only cause of hypoxia. Hypoxia is dependent on oxygen delivery. So people can then increase their RBCs and their ability to carry oxygen and therefore able to accommodate being at higher altitudes. That's how people do it. So oxygen delivery is your cardiac output times the oxygen carrying capacity of blood. And the biggest part of the oxygen carrying capacity of blood is your hemoglobin. Right, so this is why the people increase their hemoglobin because they have a low alveolar oxygen content, and then they're more able to effectively deliver oxygen to tissues. Right, you're not going to see this that often unless somebody's coming in for some sort of high altitude sickness, but 8,000 meters, 9,000 meters is where Mount Everest is. So definitely anytime you're climbing, going on high altitude with that decrease in barometric pressure, that can lead to hypoxemia. So simple, but obviously we need to be aware of it. Something we're not going to see that often unless you're going to be taking the pulmonary boards or you're going to be practicing in other parts of the country or world where you might see this more frequently than you would in, say, New York City. Something we do see, but it presents in a different way, it usually presents with type 2 hypercapnic respiratory failure, is hypoventilation. So hypoventilation, if we think about this, we hypoventilate, we're still producing carbon dioxide. So that carbon dioxide starts to build up in our arterial system. That increase in arterial carbon dioxide, we then have diffusion from the venous and arterial side into the alveolus. As carbon dioxide increases, it displaces the oxygen in the alveolus. And so our alveolar oxygen content drops. And so then we have less oxygen to engage in gas exchange to go into our capillaries. Makes sense, right? Very simple, very easy to understand. Ways that this can occur: CNS depression. So if somebody's taking opioids or if they're getting excessive sedatives, they have a stroke, something you need to consider. OHS, obesity hypoventilation syndrome, also known as Pickwickian syndrome. Pickwickian syndrome came from a Dickens novel, right? So the Pickwick Papers describes a typical obesity hypoventilation syndrome patient, morbidly obese, snoring, gagging, unable to ventilate. And this is diagnosed. You can't just look at somebody and say they have OHS. There's very specific criteria. So they have to have a BMI greater than 30, and they have to have an awake alveolar hypoventilation. So an ABG with a PCO2 of greater than 45 while they're awake. But for CMS criteria to get them BiPAP, they need to have a PCO2 greater than 53. So there's different criteria that, I have the Palm Critical Care Fellows know, something you don't need to know, but just for your own knowledge. Impaired neuronal conduction, obviously Guillain-Barré or ALS, muscular weakness, myasthenia gravis, muscular dystrophy. And then something you might see more often is poor chest wall compliance. Those elderly patients who have severe kyphoscoliosis, they can be hypoxemic because they are hypoventilating and they're also hypercapnic. So I actually was following a patient in the pulmonary clinic who actually had polio and had severe kyphoscoliosis. He's a young guy, he was like 46, but he had polio, obviously not from the United States. He emigrated here, and half his lung was crunched over and the other half wasn't working that well because he's all twisted. And I had to get ABGs on him every couple months to see what his PCO2 and his oxygen were doing, because he's at risk for hypoventilating. And finally, in my third year fellowship, we had to start getting him BiPAP because his PCO2 and his bicarb kept going up, showing that he had worsening respiratory failure. So all of these conditions can lead to hypoventilation, which can typically lead to hypercapnia, but by displacement of oxygen in the alveolus will lead to hypoxemia as well. All right, we are just about done. I'm going to give you 10 minutes of extra time to summarize the big ones being shunt, dead space, diffusion limitation. AA gradients, although not used as frequently as they should be, can help to differentiate between the two. Remember, when you're having hypoventilation and low PO2, you tend to have a normal AA gradient. When you have dead space, shunt, or DLCO limitation, you have an increased AA gradient. The AA gradient, besides being important to calculate, getting an ABG to calculate, it's also important to get an ABG because you want to look at the PCO2 to look at alveolar ventilation. I'm almost done. Sorry, guys. So I can't stand VBGs. If you really want to know what's going on with the lung physiology, get an ABG, calculate an AA gradient, calculate a dead space fraction in the lung. I've taught many of you how to do that by just looking at an ABG and exhaled carbon dioxide. So all of these things are important to know. Remember, AA gradients, they're dependent on age. They vary with age, so there's no one number fits all. And probably the biggest thing I want you to get out of this, besides just understanding the 5 basic mechanisms, the 3 being the most important, is that they don't exist in isolation. And I'm just going to hammer this point home by giving you ARDS. So you're all in the ICU with me right now. You have the patient come in with a bad pneumonia. They're in ARDS, 100%, a PEEP of 18. So they definitely have a physiological pulmonary shunt, right? We know that. You can see it on the chest x-ray. Might have had a CT. You can see it clinically just by his profound hypoxemia. But then he might develop VQ mismatch because of intrinsically the disease and microthrombi formation, right? Inhibiting the perfusion to ventilated lungs. Or by what you do, if you give him too much PEEP, you might be displacing good lung, right? So you're overdistending healthy lung, you're opening up bad lung, and now you're perfusing bad lung. And so you're worsening VQ mismatch. There can be diffusion limitation in ARDS because one of the physiological features of ARDS is loss of the alveolar membrane, right? the cells slough off, we fill with fluid and exudate and inflammatory cells. So just imagine trying to, breathe, stick a straw, in a cup of water and try to breathe through that. You can't do it, right? It's filled with fluid. There's cells which aren't working. So gas exchange is not occurring across those alveoli. So diffusion limitation is another mechanism in ARDS. One of the common features that is underrepresented, underdiagnosed in ARDS patients is the development of acute cor pulmonale. Because the lungs are under so much pressure, the pulmonary capillary pressure is increasing, the pulmonary pressure increases, you have increased right-sided pressures, and you can open up PFOs, and you can have right to left shunts, and you can introduce a cardiac shunt as well. So this is not an uncommon feature in ARDS. So another mechanism of hypoxemia in these patients. All right, it's 3:53. We are done with this presentation with hypoxemic respiratory failure. I wanted to leave a few minutes just in case you guys had some questions. I broke it down, like I said, into just basic understanding, basic pathophysiology. There's a lot of overlap and dynamic between the the three mechanisms. But understanding this framework, how you can approach the patient, I think can better help you understand what's going on in the patient and then obviously treat the patient.
Thank you, Dr. Salonia. Yasmin, you have a question? No? Any questions? Now would be the time.
Good, so everybody understands it's when you're rotating in the ICU or on screens, you're just going to know pulmonary physiology. I love it.
Yeah, but if any questions, we always know where to find you. So thank you so much for your time. Thank you for 2 hours of your day.
Oh no, I'm glad there was no screens or anything like that, unless I got like 5 waiting for me.
Okay.
But thank you very much. It's been my pleasure. I don't know if we'll be having another presentation for this year. It's almost over, but it's been my pleasure. I had a great time presenting to you guys. So
Thank you.